these, they block beta receptors and they block ham. So as compared to second gen, the first gen indications are kind of more limited. Okay. Notice here, okay, schizophrenia is a given, but the bipolar indication, that is, let's move that up. Bipolar here, it's third line because we have other first and second line medications from the second gen, third gen antipsychotics, so-called antipsychotics, and the mood stabilizers. The safety and tolerability profile for first gen is kind of mostly safety. Actually, it's just really, there are concerns. That's why it's third line. So yeah, Tourette's. Yeah, we can use haloperidol for Tourette's. Sorry, I should have added the highlight and the bold font face here, but I'm too lazy at this point. It's 2:38 in the morning. What am I doing with my life? Okay, so yeah, we can use it for Tourette's. Acute agitation, I'll talk about that in a bit. And, chlorpromazine is used for refractory hiccups, yeah, although we have preferable options. There is one rather odd use that you might come across when you talk about the so-called antipsychotics, and that is use in agitation associated with specifically intellectual disability. The question is there efficacy for these medications in this patient group? I found out during the Psych 2 training program for the College of Mental Health Pharmacy that there's apparently only one. There's only one randomized controlled trial. What did they find out? That these meds are actually no better than placebo in what they are trying to accomplish. What does that mean? It means that all this time, we may have simply been using the so-called antipsychotics not to really treat any core symptoms, but simply to sedate people, because that's what it appears to be trying to do. Remember, these are ham antagonists, H1 antagonists, sedation. Maybe that's all we're trying to do. Which is not to say that if you see an antipsychotic, you tell them to stop it. That might even be more disastrous. Context is always important. You don't just rush in headlong and like, okay, stop it. No, don't do that, okay? Medication management is a delicate process. It requires really time, collaboration, and really a lot of work. So, yeah. But in any case, that's just from a pharmacologic perspective, it appears that these don't really do much for intellectual disability beyond sedating the person, which is food for thought. Ganun na lang. Food for thought from a pickle perspective. Are we just sedating people with autism, right? Lumoa, we just talked about that. Okay. Now, onset, the first few days, it's more of you won't really see improvements in the core symptoms yet, right? So just maybe for the motor activity, agitation, you see something there. You might see some initial response in the first 2 weeks, particularly with mood. For first gen antipsychotics do not have that big an effect on mood. And if so, it's really more on the manic phases of bipolar disorder. Nothing for unipolar, just for bipolar. If you would see anything, it would be within about 2 weeks or so. For mood and maybe a little of the positive symptoms, but on average, most people will respond within about a month. So on average, usually a month. But you might see some improvements on the positive symptoms first 2 weeks along with mood, manic mood. Pero full response perhaps 4 weeks pa. Okay? Unlike with antidepressants, there are more dosage forms to deal with here. You have, of course, oral, then immediate release, then you have orally disintegrating tablets, then you have parenterals, IM, IV. So, and then you have depots, because for intramuscular injections, you have, you have immediate release, and then you have long-acting depot injectables that will last about 2 weeks to a month, to some even 3 months. So like, there's a lot to unpack there, okay? Although they will differ mainly in kinetics, the kinetics is super important. So important that NEI Psychopharm even made a Hamilton parody on that. Now, okay, I mentioned acute agitation in the next slide. I have to bring my mic. I gotta get used to this. We talk about the so-called antipsychotics being used for acute agitation because, response might take a while. So like in the meantime, right, what do? Just keep in mind that preferably, you would have already implemented de-escalation techniques. That's our non-pharmacologic strategies. And I know there are already experienced clinicians out there who are leagues more experienced than me, probably ready to critique this and say, like, you're not there in the front lines, not that you're not the one who's going to be at risk of being injured or whatever, even though people with schizophrenia are likely to be victims of violence. Sure, okay, yeah, yes, there is still risk of aggression, yeah. But at the same time, it's a delicate balance. I know it feels weird, me from behind the screen, kind of saying these things without necessarily being out there in the front lines. But at the same time, I guess it's my bias showing. My bias more towards service users, because in terms of dynamics of power, when you talk about that, even within the framework of our law, it's the clinicians who get to say whether we can waive informed consent or not and just give treatments, give meds involuntarily. So in a sense, the balance of power shifted towards the clinician, especially for serious mental illnesses like schizophrenia. So, in that sense, my bias, I would slant towards a service user talaga, in that, well, hopefully we do consider the de-escalation techniques first. Of course, that the burden there would be on healthcare systems na magbigay ng training sana on that. Training is important, of course, otherwise, it might likely not work. But if those cases don't work, on top of this is the BAP-NAPICO algorithm from the British Association of Psychopharmacology with the in collaboration with NAPICO. I'd like to add something from the context of our legal framework. Please always check if the service users have an advance directive and a legal representative in line with RA 11036, the mental health law, because these are the safeguards for service users who may be determined to have what you call temporary loss of decision-making capacity. So if they need to be given meds because they are at risk of harm to themselves or others, their consent cannot be obtained directly at the moment, right? So what to do? There are safeguards, and even though our concern is primarily meds, of course, these safeguards still will influence how the medication plan will be approached. So please always check for this. As future pharmacists, please check for this. In terms of options, we don't just throw whatever antipsychotics, because some antipsychotics have been tested, right? One thing I'd like to note here for pre-RT, when you talk about oral antipsychotics, would you consider an immediate release or an orally disintegrating tablet? Because there is a misconception that orally disintegrating tablets for antipsychotics will work faster than the oral plain immediate release tablets, because, well, ODTs will disintegrate in the tongue, so supposedly faster absorption. That's not true. ODTs and the regular immediate release tablets, they start working at about the same time. Pretty much. They work at the same time, basically. So, when are ODTs used? Well, ODTs, they are used mainly when there is difficulty with swallowing. For instance, hirapan siyang mag-swallow. That's one medical concern, definitely. Another is if this has happened in clinical practice when people try to hide the tablet and then they spit it out later. It makes it more difficult to hide, because if they try to hide it, it will just dissolve in the mouth, right? And be swallowed eventually. So that's another thing. Otherwise, no difference in terms of onset of action, all right? No difference. Then, of course, consider these before you go to the parenterals. We don't have all of these, okay? We don't have lorazepam. It's in the PNF, but I can't find an FDA-registered version. We do not have buccal-midazolam. We do not have inhaled loxapine. We do not have oral promethazine. We have oral diphenhydramine. That's the closest relative, I guess. So it's going to be either oral difen, which is already a very big extrapolation, or these. Yun. Okay? Now, contraindications. Some of these you can extrapolate based on their clinical properties or even their MOA. For instance, haloperidol. Remember, these are haloperidol compared to, say, chlorpromazine, is a more potent dopamine type 2 receptor antagonist. That means in Parkinson's, remember, your D2 receptors are already disappearing because the neurons on which they are placed are dying. They are literally dying. So, if you give a drug that potently blocks the remaining D3 receptors, that's gonna be a big problem. Okay? Well, chlorpromazine, because it is a chlorpromazine tamoxifen. Tamoxifen, I'll explain that in so-called antidepressants bit. We talk about contraindications, but in short, chlorpromazine is a 2D6 inhibitor, which is important for tamoxifen. So just check out the explanation with fluoxetine and paroxetine for that. One thing you might be wondering is why strong anticholinergics like chlorpromazine are contraindicated with potassium salts of all things. So potassium, like potassium chloride, I mean, popularly known by its brand name. I don't like saying brand names, but fine. Kalium Durule. Why exactly? The thing with potassium is potassium, if it stays too long in the gut, expect ulcers. Why? Why are there ulcerations with prolonged potassium exposure? We're not sure. One hypothesis is that potassium is directly caustic to the gut lining. Another hypothesis is that potassium causes spasming of blood vessels, veins, in the gut, which may then lead to ulcerations. But, nothing clear. Where does the potent anticholinergic come into play? Because, right, chlorpromazine is a relatively more potent anticholinergic than, say, haloperidol. Anticholinergics, they slow down gut motility. Right? Opposite of diarrhea would be constipation. That's due to one reason is slowed gut motility, blocking muscarinic receptors and all that. And slowing down gut movement will keep potassium longer in the gut. You don't want that to happen. And so, generally, we just want to keep strong anticholinergics and potassium salts apart. Bone marrow suppression. Why? Because many of these drugs can rarely cause a granulocytosis. And if the person already has a baseline suppression of their bone marrow function, neutropenias, that might stack, right? So, yeah, some of these you can rationalize naman based on clinical properties.